Okay, good afternoon. We're going to go ahead and get started today. Welcome to the House Standing Committee on Health Services. Today is our fourth meeting. Things are going fast now. Things are picking up, so it's starting to things are starting to move. Welcome. Thanks everyone for coming today. We don't have a large agenda, but we have an important agenda, so I appreciate everyone being here. Please silence your cell phones, and we will go ahead and get started. DJ, please take the roll.
Representative Bratcher. Here. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson. Here. Representative Fleming.
Present.
Representative Gordon.
Yes.
Representative Holloway.
Here.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor. Representative Rayburn.
Here.
Representative Raymer. Representative Riley.
Here.
Representative Sharp.
Present.
Vice Chair Duvall.
Here.
Ranking Minority Member Wilner.
Here.
Chair Mosier.
I'm here. Okay. We have a quorum established to do business, and we'll go ahead and get started. The first bill that we will hear is House Bill 470, and I will make my way to the table. If my guests could please join me, I would appreciate it. And I'll hand over the gavel to my co-chair, my vice chair. Thank you.
All right, as you make your way to the table, we'll go ahead and introduce yourself for the record. And after you introduce yourselves for the record, we'll talk about the committee sub.
Okay, thank you, Mr. Chairman, and thank you, committee, for allowing a few minutes to discuss this important bill, this small change but important bill. I am Kim Mosier, State Representative for the 64th District.
Hello, members of the committee. My name is Elena Sweezy, and I'm with Lane 13 Consulting.
Hello, committee. I'm Michael Burba, and I'm with Kairos and Recovery Now, LLC.
Very good. I think we have a committee sub.
We do. We do.
We have a motion and a second.
Mm-hmm.
Any discussion? Yes. Representative Marzian?
Thank you. I would just like to see what the difference is in the two.
Okay, yeah,
Thank
happy
you.
to discuss that.
Thank you.
So all the committee sub does in the language is strikes that we permit a temporary alcohol and drug support specialist to provide the same services be reimbursed at the same rate as a registered alcohol and drug peer support specialist. They don't do entirely the same job, so it was at this time we're doing a little bit of cleanup from House Bill 505. That was one change. And then just remove any limits on the maximum number of hours of direct client care that may be provided by the registered alcohol and drug peer support specialist.
All right, we have a motion and a second on the sub. Any other discussion? All in favor, say aye.
Aye.
Any opposed? Motion carries. Please
Okay.
proceed.
Yeah, thank you. I have some experts with me who really were very helpful in crafting this legislation. But in a nutshell, what we are doing is moving extending a date that the ADC board in House Bill 505 had to have peer supports registered in order to be Medicaid reimbursable. We are moving out that date to give them more time to do this. The problem was that ADC and the cabinet didn't have the regulations promulgated in time, and it created kind of a backlog. And the other change that we are doing, we are making is just creating a work group to look at oversight of the entire system of peers. We have peers who are substance use, dealing with substance use disorders, mental health, reentry, gambling. We have a wide array of peers at this point, and we want to look at best practice for oversight, and that's basically it. So I will hand it over to Elena if you want to say anything else.
Yeah, thank you, Co-Chair Duvall and members of the committee. Can y'all hear me? My name is Elena Sweezy. I'm a social worker and a lobbyist with more than a decade of experience in peer-led recovery. I was the second person in Kentucky registered as a peer support specialist when I was credentialed back in 2016. I'm also the founder of Lane 13 Consulting, and I represent providers who rely on peer support as a core part of their treatment. Since January 1 of this year, Kentucky has experienced a peer support workforce shortage caused by implementation challenges from House Bill 505. This is disrupting services for our providers. House Bill 470 is simple and it's critical because it includes an emergency clause to stabilize the workforce. It extends the implementation timeline to allow credentialing boards to address regulatory and application backlogs. And it requires a working group to deliver recommendations for an effective, efficient, and evidence-based credentialing body by November 1st of 2026. We don't feel like the cabinet or the ADC board is the good place for our peer support. They need their own board. During the interim, I worked with other experts and stakeholders to understand the impacts of House Bill 505 by gathering input from DMS, BDID, the ADC board, and providers themselves. The work made it clear that peer support and other paraprofessional roles need a better infrastructure, one that addresses billing, regulation, and workforce stability without undermining the value of peer support. So Kentucky needs a peer support framework that is reliable, ethical, effective, and sustainable while honoring the lived experience, which is the heart of this work. So I respectfully ask for your vote for House Bill 470.
All right, we have a motion and a second. Do you wish to proceed or? Okay.
I'm fine.
All right, very good. So do we have any questions? Representative Marzian?
Thank you, Madam Chair. Now, on this board, it doesn't say who is responsible for appointing. I don't see it anywhere.
There's not one. It's a work group.
Thank you, Representative Marzian. Yeah, this is really an informal work group, and we have done quite a lot of work with the Behavioral Health and Developmental and Intellectual Disabilities Department. And because they oversee some of the peers now, the mental health, I believe that that's really where this will rest.
Okay.
All right, very good. Any?
Thank you. And I think there were some people signed up that wanted to talk about the bill, if that's okay.
Yep.
He knows.
Are there any?
Thank you.
Are there any other members with questions? All right. Very good. We do have a couple of folks signed up, so we'll have probably have y'all move out of the table for a moment, and we'll have Mr. Frank Miller Jr. come forward from Grin Grant, and so we do want to keep the committee moving, and so we're going to do a 3-minute. So if you'll introduce yourself for the record, and once you do, you'll have 3 minutes to say what you need to.
Thank you, Chairman Duvall, or Vice Chairman.
And make sure your mic is on and introduce yourself for the record.
How's that? Thank you, Vice Chairman, Chairperson Mosier. My name is Frank Miller Jr. I'm a lawyer and from Lexington. I'm also a registered legislative agent for Grin Grant Incorporated, which is a nonprofit company that operates an AODE, alcohol and other drug treatment entity, and also operates a training branch and is one of just 3 approved trainers by the Board of Alcohol and Drug Counseling to conduct training for alcohol and peer support specialists, alcohol and drug peer support specialists to achieve registration with the board. The time is short, so I'm going to focus on what I think is probably the main flaw with House Bill 470. it suffers from the same flaw that House Bill 505 did and does, in that it attempts through a new section of KRS 222 to effect changes in insurance, in particular Medicaid benefits or coverage or eligibility, simply by telling the Cabinet for Health and Family Services to promulgate regulations that essentially represent a wish list of what you would want in a statute. But the statute does not enact any change to Medicaid. The statute does not tell the public and those providing services to them that there is now a difference in a benefit or a coverage. Now, we know that when the legislature is giving a job to an agency, there has to be an enabling statute. We know from the recently filed bill, Representative Wilner, I believe, was the primary sponsor, that said we're going to now, it shall now be a covered benefit under Medicaid to provide doula services. It's a short bill, but it does a couple of things. It says we are setting this up to be a benefit. Now, Cabinet, go and promulgate regulations consistent therewith. And it also says that this is the authorization that's required by statute under 205 subsection 5372. That's a prerequisite to the Cabinet doing any regulation on this bill, on the doula bill. Now, the regulation.
Mr. Miller, we do have 3 minutes. I'll give you 30 seconds or so to kind of finish up your remarks, please.
222.233 is unenforceable. It does not have an enabling statute. It simply, and that's why the Cabinet never did produce any regulations. It can't. There's no authority that it can act upon because the legislature has not made a decision on policy. It has simply told the Cabinet to go write some regulations. It's vague, it's not precise, and it does not, will not stand a challenge, which we are in the process of making to that law. And this bill has the same problem.
Thank you. Thank you. Do we have any questions from the membership? All right, very good. Thank you for coming today. Thank you for your testimony. We also would like to have Sarah Vaughn come up from MedBill Consultants. Ms. Vaughn, if you'd make sure the green light is on and introduce yourself for the record, and you'll have 3 minutes to give your testimony.
Thank you. My name is Sarah Vaughn, and I'm with MedBill Consultants. I work a lot with many different behavioral health, AODE facilities with billing and help consult them on new things that are coming down. My main question on 505 or on 470 is the new addition to a behavioral health multi-specialty group, of telling a behavioral health multi-specialty group that they can only employ a RAD peer support. A behavioral health multi-specialty group standalone does not have an AODE because their primary diagnosis is mental health, and that is what they do. When a behavioral health multi-specialty group starts dealing with a primary diagnosis of SUD, they must have an AODE. So my main question with that is, why would this be imposed on a mental health practice to tell them that we have to employ an SUD peer support? There are new things within 2025 that came down. It is the RISE initiative that works with mental health. There are programs going up. These programs have 24-hour care for people that do have severe mental health. The way that these programs are staffing was going to be with mental health peer support specialists because they have to have 24-hour care. If we're being told now that a behavioral health multi-specialty group has to have an RED peer support, how are these programs going to move forward with a mental health peer support? A BHSO1 is also primarily mental health. A BHSO2 and a BHSO3 are substance use. When the regulations are written, will there be a separation of how the regulations are written to go to behavioral health and substance use? Will we have two different sets of regulations? A RAD peer support specialist, it says, can treat or can see a client with a primary diagnosis of SUD. A certified peer support sees a mental health client. When you are submitting prior authorizations, which peer support has to do for services through the MCOs, when we submit a prior authorization for peer support, we have to put what the primary diagnosis is. If it is SUD, it goes to a RAD peer support. And
We'll give you 30 seconds to finish up. Thank you.
If it is mental health, it goes to a peer support, a regular peer support. So the co-occurring part, Medicaid, goes by their primary diagnosis. And my last thing is, if we submit something to DMS, DMS submits it to CMS, and if CMS doesn't agree with that and they deny it, is the state willing to take on the funding for the peer support if CMS will not give funds for it? Thank you guys for your time.
All right. Thank you. Do we have any questions for Ms. Vaughn? Representative Marzian?
I have a question, but I don't know if it's for you or the cabinet. What happens to the current mental health peer specialists who are not SUD certified?
The way the bill is written, they can't work in a BHMSG, they can't work in BHSO, and they can't work in an AODE, so I don't really know where the plan is for them to work.
That may be for the cabinet, I don't know. Thank you.
You're welcome.
All right. Very good. All right. All right. Thank you, Ms. Vaughn. Thank you for coming today. Representative Mosier and your guest, if you want to come back to the table and give you an opportunity, if you want to respond to anything, you're welcome to. And
Sure. Yeah. I think there are probably a few things. I don't know, Michael, if you want to respond to the first questions or concerns. Yeah. No? No. Okay. All right. What I would say is the alcohol and drug, the behavioral health service organizations and BHSO multi-specialty groups, this does not require them to hire anyone, but it just says if they hire a peer for substance use treatment, that they should be registered. There's no requirement that they absolutely hire this person. And just by virtue of some of the comments and the questions, you see the confusion that we have with the peers in different departments, which is exactly why we need one board to oversee and simplify the process and make sure that if we're requiring registration, that we use the same language, that, you know, if it's certification somewhere, I mean, it is confusing right now. And I mean, that's my rationale for setting up this work group to look at oversight and probably putting in place a new board that oversees everyone. Do you have anything that you'd like to add?
Yeah, I'll just add, I think that the multi-specialty group language was added in because there are a lot of providers that all have to kind of live up to this standard, even if they do have primary diagnosis of mental health with people in their facility, which a lot of them do. And the multi-specialty groups were a loophole for people that didn't have to do what all the other behavioral health providers are doing. And so that's where that came from. That's why it was put in there. That's all I really know about that part of the bill. But it is very confusing, and that's why we do need we need a new place and a new body for this these paraprofessionals. And there's peer support, but there's also CSAs, community health workers. So there's other paraprofessionals that are really unregulated that we need to really think about.
Any other questions? Oh, Representative Camuel.
Yes, thank you, Mr. Chair. I've been trained very well by our A&R chair to always ask about a fiscal impact, and that's what I'm not seeing on this. Is there a fiscal impact statement? Do we know what the cost will be, what it will cost us, or what it will cost to implement?
With this bill, there should not be a change in the fiscal impact whatsoever, because all this is doing is moving a date certain. In fact, I mean, I think it might even be negative, because we're striking some of the language that requires pay parity for differing counselors. So there's no, thank you. There isn't a fiscal impact on this bill.
Thank you.
And there wasn't one required.
Thank you.
And we have a
May I follow up?
Yes.
Just real quick. Well, it's not a follow up. It's actually my second question. What I was trying to figure out in reading this, so the work group, I'm just trying to get clarification.
Mm-hmm.
The work group is not appointed. Is that correct?
Yeah, we went back and forth about how to establish that within the cabinet, and just decided that having a group of experts who can come together and really, impart their ideas about the organization or the organizational structure of overseeing, and just making sure that everyone is following the same training rules. I think we need a similar curriculum for all peers, basically, and then perhaps a subspecialty for the different areas of their work. So, and there's so much overlap in, as Elena said, the mental health issues intermingled with substance use treatment. And so I think it behooves us all to improve the training and make sure that our peers who are treating individuals with severe issues are properly trained. So that's kind of what we tried to tackle in 505, but there's more work to be done. And we didn't want to try to rush and do it all in one bill. We want to be thoughtful about this. So that's kind of where the work group idea came in.
Thank you. I appreciate it.
Yeah, of course.
We have a question from Representative Burke. All right, and one more question from Representative Marzian.
One more question. Thank you. Would you all speak to the cost of the training for the peers? I've heard that it was $75, but now it's up to $600, and it's really difficult for folks in recovery to pay that amount. Plus, then they have to pay for a test, so they're having trouble getting employed when the cost has gone up so much.
Yes, absolutely. So there are some nonprofit organizations that get grant money to provide the peer support training, and then there are some for-profit companies that have a cost to pay a facilitator. The trainings also vary. So you have some people that watch videos, you have some virtual, and you have some in-person trainings. So I think that there's a variation of training providers that provide different trainings. I know that for 40 CEUs, that's a lot of CEUs, and I know people from the CADC board and the cabinet, they charge $150 for 20 CEUs. So I think that I've not seen any training. In our training at Lane 13, our training is $175 for 16 CEUs. And that's the only training that we've ever provided to peer support. And I think that if you look at all kinds of different degrees and credentials, people have to have a little skin in the game when it comes to training and credentialing.
All right, very good. We have one final question from Representative Callaway.
Thank you, Chairman. So I'm not very familiar with this practice, just full disclosure. And there have been a lot of acronyms thrown around today between all the testimonies.
Sorry.
So I just want to make sure, because I'm hearing some conflicts in the testimony. And when I'm reading this, it does appear that we're saying they are these agencies, and we've included the behavioral health multi-specialty groups or any entity that bills for peer support services only employ. So it does sound like there is a requirement to hire these individuals. So like I said, I'm trying to keep up with the process and the acronyms and just make
Right.
sure that we're doing everything we can to help some vulnerable people in some really bad situations.
So it says, and thank you for pointing that out, and I'm happy to try to clarify it, only employ an alcohol and drug peer support specialist who is registered. So they can still, they could employ someone now and they just wouldn't be Medicaid reimbursable. But this is reverting back to the pre-House Bill 505.
Yeah, just to clarify, all this is already done. This happened 2 years ago in House Bill 505, so that's already in statute. A lot of all these different individuals have to be, or these different entities have to be registered. What the multi-specialty group was added in 470 along with all the other providers. But this bill really just kicks the can down the road and changes the date from January 1 of this year and moves it to 2028 to give time for a new process. And we have worked with the Department of Behavioral Health, and they are already creating a new board. So they're going to appoint a lot of people to this process because they're already in the process of doing this work. So hopefully that clarifies too.
But, and that's why we are working with BDID to Behavioral Health and Developmental Intellectual Disabilities Department within the Cabinet for Health and Family Services. I'm so sorry. We do speak in acronyms. But we are, as Elena said, they're in the process of looking at a new board structure. And so that's why we feel like now is the time to work with them to see if, they're pretty specific to behavioral health. And I think what we need to do is look a little more broadly at paraprofessionals. And we do have all of these navigation kind of systems and workers who are helping patients on the front end. And we just want to make sure that we're not duplicating services, that, we're not ending up costing the state more money, and that individuals are getting the care that they need and that they expect.
All right. Due to time constraints, we'll have our final question from Representative Fleming.
Thank you, Mr. Chairman. This is a pretty simple bill, and I know there's been a lot of discussions about this. We're going off the track a little bit, and that's fine. This is a good situation when you kick the can down the road because we got to get a better handle on the peer-to-peer support. And part of what I'm speculating, and verify this, Madam Chair Mosier, that we saw an escalating amount of Medicaid payments going from a couple $100,000 to close to $200 million over the past couple of years. And I don't think there's a control function. I don't think there's an oversight. I don't think when you have people coming into this process to be qualified, to be credentialed, to be registered, that provides authenticity and avoids fraud. And so that's why I think this is a good move to do this in order to try to get a better handle on what's going on, because our Medicaid situation is out of control. This is one component in the wheel that we need to put more control on that particular health care. Thank you.
Right.
All right. Very good. So we have a motion and a second on House Bill 470 as amended by House Committee Substitute. DJ, please call the roll.
Representative Bratcher. Yes. Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson. Yes. Representative Fleming.
Aye.
Representative Gordon.
Yes.
Representative Holloway.
Yes.
Representative Marzian.
May I explain my vote? Right now, I'm going to pass because I think it is such a complex issue. We have so many, 3-minute testimony is not enough to understand what's going on. I read this bill like 3 times last night. And I would like to see all of the groups come together and pull something together that could satisfy everyone, but I'm going to pass right now.
Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Aye.
Vice Chair Duval,
Yes.
Ranking Minority Member Wilner.
I'd like to explain my vote. I am so on board with this concept. I love the idea of bringing together all the different peer support specialists to be the one. You know, it's grassroots up, and so the folks who are directly impacted. So I really like that. I was, came in thinking I knew what the bill was about. I'm now a little bit confused, and I think in particular in section 1B, that language really is confusing. So I'm going to pass for today, but I look forward to getting that cleaned up. And I know you said you're going to look into that. So thank you. And I'll likely be a yes on the floor. Thank
Okay,
you.
I'm happy to work on that.
Thank you.
Mhm.
Chair Mosier.
Yes.
All right, very good. So House Bill 470, as amended by the committee sub, passes with favorable expression. I do believe we have a title amendment. Do I have a motion for? I have a second. All in favor, say aye. Any opposed? Motion carries. Very
Okay,
good. Thank you.
And I'll just point this out to everyone. You do have a list of all the 13 agencies and organizations who support this and have worked on this. So thank you so much.
All right, very good. So Representative Gordon, if you'd make your way to the table with any guest as Chair Moser is making her way back.
Okay, thank you. Well, welcome. Please introduce yourself for the record and proceed.
Representative Deanna Gordon, District 81 from Madison County, and I do have a guest.
My name is Dana Feldman. I work for the Kentucky Department of Agriculture as Executive Director for the Office for Consumer and Environmental Protection.
This resolution matters because it does three essential things. First, it recognizes and scales a proven Kentucky partnership, the Kentucky Hospital Association and the Kentucky Department of Agriculture, into a statewide framework for success. This resolution aligns state agencies around a clear direction, integrating nutrition into care and public health, and intentionally connecting that work to Kentucky-grown products. Secondly, it strengthens health outcomes through practical, measurable action. Kentucky is carrying a heavy chronic disease burden, conditions like diabetes and heart disease that are deeply connected to diet and access. Our hospitals see the downstream effects of this every day. They also know we cannot outspend a chronic disease crisis with treatment alone. Food is medicine interventions like produce prescriptions and medically tailored meals for high-risk populations are designed to improve outcomes and reduce avoidable costs. This resolution directs agencies to coordinate with the Kentucky Hospital Association and KDA and other partners to advance these pilots and, importantly, to evaluate results so we can measure impact and make smart policy decisions going forward. Thirdly, it supports rural prosperity by creating reliable opportunity for Kentucky growers and producers.
Okay, we have a motion and a second on the resolution. Would you like to proceed with your testimony?
I'm good. Anything you need to add?
No, I just wanted to say thank you for having me today, and on behalf of the Department of Agriculture, Commissioner Schell, our sponsor here, and the Kentucky Hospital Association, thank you.
Yeah, and I'll just add thank you for bringing this. This is really important as we do try to get some more control over our chronic disease here in Kentucky. I think it's really important that we identify what we can and should be doing And definitely food as medicine is a step in the right direction. So,
Thank you.
Thank you. Do we have any comments or questions from the committee? Okay, seeing none, DJ, please take the roll. Oh, did we have a question? No, okay, sorry. All right,
Representative Bratcher, Representative Bray, Representative Burke,
Yes.
Representative Callaway,
I'd like to explain my vote, please. So thank you so much for bringing this forward. 6 months during the interim, our MAHA task force met, and this was key. I mean, we kept circling back. Everything came back to, food is medicine. Bottom line, it was a mantra for us. So I'm really excited to see this happening. I think this will spark more good conversations, good legislation, whatever we can do to come alongside those who are actively pursuing this goal with us. So thank you for that, and I'm a aye.
Representative Camuel,
Yes.
Representative Dotson, Representative Fleming, Representative Gordon,
Yes.
Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Aye.
Vice Chair Duvall.
Explain my vote. Representative Gordon, thank you for bringing this important resolution. The Food is Medicine initiative is going to be critically important to the state of Kentucky going forward, because we've got to look at our obesity and our diabetes rates, and the path forward is making sure that we're eating better and we're educating our public as to how to properly prepare food. So thank you for doing this, and look forward to the fruit that it bears.
Thank you for your
And the answer,
comments.
and yes.
Ranking Minority Member Wilner,
An enthusiastic yes.
Chair Mosier.
yes. Okay. House Joint Resolution 25 passes with unanimous support and should pass the same on the House floor.
Thank you, Chair Mosier.
Congratulations.
Thank you,
for
Chair,
bringing
and members
this.
of the committee.
Okay. All right. Our next meeting is next week. I don't know the date. February 12th here at in room 149 at noon, and we look forward to seeing you all then. I do want to point out that we have a group of nurses from Lindsey Wilson University today, nursing students. So welcome, and thank you for your work, and we look forward to working with you in the future. Thank you for caring about the health of Kentuckians. All right, seeing no further business, we stand adjourned.